But we begin with the state of COVID. Here we go again. It is the middle of October, and no surprise, we'd been warned about this. COVID cases are on the rise, as are hospitalizations. And there's a new kid in town, BQ 1.1, a coronavirus subvariant that many experts feel could drive a new wave in Europe and here in North America by the end of November, potentially emerging as the dominant variant this fall and winter. So what do we know about BQ 1.1? Let's bring in Professor Raywat Deonandan, an epidemiologist, associate professor at Ottawa University, and a COVID-19 science communicator. Thank you, Professor Deonandan, for joining us on the feed. Is it okay if I call you Ray through this interview? That is your name.
Absolutely.
And speaking of names, there's a new kid in town, a new kid on the block, BQ 1.1. What does it stand for, and what is it about?
Well, speaking of names, this one has a fairly ominous name. They call it Cerberus, which is the name of the three-headed dog that guards the gates of Hades in Greek mythology. That's a little scary. And BQ 1.1 is actually the child of another subvariant called BQ1, and its name is Typhon. So these names keep on coming. It shouldn't be that scary, but it kind of is sometimes. The thing about BQ 1.1 that has a lot of virologists nervous is that it has 3 mutations on the spike protein. And not only does that make it a really contagious subvariant, in fact, possibly the second most contagious one currently circulating, but also it seems to evade the immunity offered by our best antibody treatments. So right now we have a suite of antibody treatments that are used primarily by immunocompromised people who can't be vaccinated. And if this variant is not effective against any of those treatments, well, that's a dire predicament for a lot of people who rely on those treatments.
And what about the efficacy of the bivalent vaccine that people are getting into their arms in Canada right now? Does it evade its efficacy?
It's a very good question, and something that people are working on. So right now, in Canada, we have 2 bivalent vaccines. We have one that's tuned to BA1, that's the one made by Moderna, and we just authorized one that's tuned to BA5, that's the one made by Pfizer. And BA5 is now the dominant subvariant in North America. However, it's being rapidly displaced by these new subvariants, BQ 1.1 among them. The thing about BQ 1.1 is that it's a descendant of BA5, not of BA1. So it strikes me that maybe I'm a little bit hopeful that the Pfizer BA5 tuned bivalent might be effective against this subvariant. We don't know yet, and so that has to be a priority for the lab people to figure that out.
And the public, we're willing to roll up our arms, and some of us are grateful that we've got this opportunity in Canada to have free vaccinations against COVID-19, but we're not sure whether we should be saying to wherever we're getting our vaccination, I want Pfizer or I want Moderna. I mean, therein lies a real issue. Should we just take what we can get?
Yeah, that's a tough question. I think, you should take what you should get, but it comes down to what your individual risk scenario is. How prevalent is the disease in your community? How vulnerable are you? How far it's been since your last booster? If it hasn't been that long since your last booster, then it might be worthwhile waiting until you get a BA5 tuned one. But frankly, the advantage offered by a booster, the lion's share of that advantage is being boosted by anything, even the original vaccine. So the additional advantage offered by Omicron is by the Omicron contingent of the vaccine is a few percentage points more. So most of the population benefit will be in being boosted by anything. But if you have a choice, get the BA5 one.
And, prevention is key, but we need to understand more about BQ 1.1. Is it more transmissible, more easily transmitted from one person to another? Does it make a person sicker than some of the other subvariants or right from the very beginning, COVID-19 and Alpha and Delta and you name it? How do you describe it?
Well, it looks to be more contagious. So the doubling time is about a week. That's the number of days it takes for the proportion of cases in the population to double. And in Canada right now, the hotspot seems to be Quebec, but it's growing in the U.S. Fairly quickly. About 10% of UK cases are BQ 1.1. Maybe we're seeing it in Belgium and France as well. 8 to 10% of New York State is BQ 1.1. But in terms of seriousness, again, we don't know. However, some early data suggests that it seems to have a more likelihood of giving you diarrhea and vomiting, so gastrointestinal disorders. And maybe there's some concern that maybe it's more trophic towards the lower lung, which means that, more likely to have lung infections. We haven't seen that since before Omicron. So if that's the case, I'd be a little concerned. Again, we don't know yet. We're waiting for data.
It's interesting, these variants and subvariants, they don't know any borders. So you talk about its appearance, BQ 1.1 in Quebec. What's to stop it from coming into Ontario, and how will it, and what will it look like when it gets here?
It's probably already here.
Yeah.
And nothing's going to stop it getting here, and it's going to come here, in my opinion. So what will stop it coming here is if another variant takes over, keeps it out. So nothing good will keep it out, only more bad things. So it looks like we're going to be colonized by BQ 1.1. That's my prediction. There's another big baddie out there in Asia called XBB, which is even more contagious. It may pop its head in here as well. But I fully expect us to be colonized relatively quickly. And by the way, we already have been colonized in Ontario. It just takes some time for the cases to mount. Many experts are suggesting that BQ 1.1 will drive the winter wave.
And it sounds as if that's not that it's when. So it's almost as if it is understood that we are going to have a winter wave. Is that right? I mean, there's just no getting around it.
Well, nothing's guaranteed, but it does seem that way. If I were a betting man, I would say it's likely. The question is, has it been decoupled from serious outcomes? Now, the decoupling from deaths, I think, has happened. We're not in the same scenario we were in March of 2020. Cases will rise, but the deaths will not rise at the same rate. However, since this disease is so contagious, more people will become infected. Therefore, we're probably going to see more people with some serious outcomes like hospitalization and death. The individual risk profile will not change, but the population profile will probably get worse.
Ray, how is this being tracked at this point? We're not getting daily case counts. We're getting, little bits and pieces here and there. We understand that wastewater surveillance is going on, but how is it being monitored in Ontario? And this would be BQ 1.1 or any other ugly subvariant that rears its head.
That's a very good question. Now, historically, we have community testing, and you just take a sample of that community test and you do an additional laboratory screening to determine what proportion are certain variants. That's being done still, but the number of community tests is so diminished and the sample is not random that it's hard to get a sense. It is possible to do this on wastewater testing. I'm not sure if it's being done yet, but definitely we were testing wastewater for other kinds of variants. It's a matter of retasking the machinery to test for these new subvariants. I suspect that will be the case as well. But as a result of all the things you mentioned, we are flying a little bit blind. We have less data now than we did at the peak of the pandemic, and that's not a good way to manage public health.
Non-scientists like myself figure that every time a virus mutates that it loses strength. Wrong. I know that I'm very wrong about that, am I not?
Yeah, it's not true. It's not true at all.
Yeah.
The assumption there is that the evolutionary pressures are compelling an organism to move towards not killing its host. Well, there are other ways to make your life miserable without killing you, right? And it comes down to, does it take long enough to kill you to still allow you to pass the disease on? If that's the case, then there's no disadvantage in killing you, evolutionary speaking. There are many cases historically where diseases have become more virulent and more lethal, not less over time. So it's a mistake to rely upon evolution to get us out of this.
Will it ever stop mutating? And I guess I go back to the coronavirus, to COVID-19 and all of its variants and subvariants, but will it ever stop mutating?
It comes down to how much transmission is allowed to happen. So long as people are becoming infected, the opportunity for mutation arises. Now, with the flu vaccine, every year we see mutations for this very reason. A lot of transmission is happening. A lot of genetic material is being swapped between animals, humans, etc. With this disease, if we get a pan-coronavirus vaccine that is good for all variants and get enough people globally vaccinated, then the opportunity for transmission comes down dramatically, and the opportunity for evolution comes down dramatically as well. However, the odds of that happening, we'll see. We'll see. It'll take a couple of years probably for that to happen. My prediction is no, we're going to see mutation happen, and we're going to have this disease with us for a long time, resembling the flu in its mutation profile, but being more serious than the flu every season.
So how do we protect ourselves? And let's first of all talk about the vaccine that is available right now.
Well, in my opinion, we should get the bivalent booster if you're eligible. Get it as soon as you can. Also, some tools are good against all variants. And these tools include masks, ventilation, staying home when you're sick, all that good stuff. Right? So these physical barriers work against everything. Ventilation is something we don't talk enough about. I have a portable CO2 monitor that I take into environments where I have to be unmasked, like giving a lecture or something like that, and that tells me how much fresh air is in the room. And that's a good monitor to determine, how quote-unquote safe an environment is. Do we have to live like this forever? No, I don't think so. Just until we have enough population immunity to get the threat down to something manageable. We're not there yet, but we will get there eventually.
What's your best advice? We're smack in the middle of fall. We're marching toward winter in a couple of months, and a lot of people are quite fearful of what is to come. What's your best advice on how to cope with this, how to protect, how to enjoy life, but also how to keep these variants and subvariants at bay?
Live your life, absolutely. Like go to your social events, see your family, hug your loved ones, etc. But be vaccinated. Yeah, my philosophy is get vax to the max. So whatever you're eligible for, get it. Encourage your loved ones to do so. Try to associate with people who don't have the disease. Use rapid tests to your best ability. They do work. They use, not to their greatest efficacy. Speaking of which, there is some concern that BQ 1.1 may not turn up as readily on a rapid test as other variants. We don't know that yet, but it turns up enough that it's still useful. So use a rapid test to get yourself out of isolation. And if you have symptoms of any kind, try not to socialize, and try not to socialize with people who have symptoms of any kind. These small steps aren't perfect, but layered on top of each other reduces your risk profile dramatically. This is about reducing probability, not eliminating risk entirely.
Very well put. Professor Ray Deonandan, epidemiologist and associate professor, Ottawa University. Thank you so much for joining us on The Feed. Fascinating.
My pleasure. Thank you.